Hello, everyone. I'm Dr. Carmen Puliafito. I'm pleased to welcome back to Retina Synthesis Dr. David Boyer of the Retina Vitreous Group of Los Angeles, also adjunct professor at the Keck School of Medicine at USC. Gave a fascinating presentation at Angiogenesis 2022. David, welcome to Retina Synthesis.
Thank you very much, Carmen. It's good to see you.
Can you tell us a little bit about the agent and its novel mechanism of action for diabetic retinopathy?
Yeah, it's my pleasure. APX 3330, I presented the phase 2 oral drug inhibiting novel target of REF1 with a dual anti-VEGF and anti-inflammatory mode of action. I am a consultant for the company and did participate in their trial. REF1 is a very novel target. It's a protein that regulates transcription factors, particularly HIF1 and NFKB. And these two transcription factors are very important, as you know. They're upstream of VEGF and they're upstream of many of the cytokines. So they basically, this one small molecule that's given orally is able to block both of these HIF1 and NFKB and create both an anti-VEGF and an anti-inflammatory effect with this drug. It represents one of the first in class drugs of a mode of action, oral drug. And I think this would be nice to have. You can start patients a little bit earlier, depending on obviously the safety, and may be able to reduce progression of patients that have diabetic retinopathy. So there have been a lot of preclinical data that's been presented and published on this. We know that VEGF levels go up and down in models, and pro-inflammatory cytokines, TNF-alpha and interleukin-6, are blocked by macrophages. That this has been proven in APX 3330 in experimental trials. In the well-studied CNV mouse model, oral gavage really reduced the clinically significant CNV size by about 50%. So we're really showing that it is very comparable to anti-VEGF, again, being given orally. We have some functional data. This is a drug that actually has been around for a while. It was developed targeting inflammation in 300 healthy and hepatic patients in 10 phase 1 or 2 clinical studies. So it's been studied for a long time. It had excellent safety, and it actually showed it was focusing both on inflammation as well as angiogenesis. And Ocuphire, the company that sponsored the trial, was able to use this preclinical and clinical data so that they could actually go out and support the IND very quickly. They didn't have to show safety, as this has been well established in the past. So the APX 3330 is bioavailable, and it has a pretty constant PK profile. So it's many times higher than what's been done experimentally and able to hopefully suppress both the angiogenic and the inflammatory component. In the safety profile in 340 patients that were dosed at higher levels, 720 milligrams per day for 1 year in some studies, showed a very small, about 5% risk of going on to developing diarrhea or any other drug-related AEs. In our study that we've been doing, we had one patient, he had mild diarrhea, and that's the only patient, and we had approximately over 20 patients in our study. So we're going ahead with 600 milligrams of a single dose of 600 milligrams a day, and based upon the fact that it seems to be very safe. And so the Zeta trial was randomized to 25 sites. They want to enroll about 100 patients. And they were studying the typical group of patients, 47, 53, and 61. These were moderately severe to severe NPDR and early mild proliferative diabetic retinopathy and non-central diabetic retinopathy. They didn't treat patients with central DR. The primary endpoint was 24 weeks, and what we're looking for is a 2-step improvement in diabetic retinopathy severity and other secondary endpoints, including central subfield thickness, corrected visual acuity, labs, etc. The inclusion and exclusion are just similar to what we normally would see in a group of patients that were looking for improvement in diabetic retinopathy severity. it would be noted that you could have center-involved diabetic macular edema in the fellow eye, though you couldn't have it in the eye that was being treated. So we will get some data on fellow eye treatments. At the time I gave the lecture, about 70% of patients were enrolled. We're close to completing enrollment totally. There were some mild AEs, considered like vertigo, rash, itching, and frequent bowel movements. 2 were considered moderate, increase in diabetic macular edema and diarrhea. And those were in the same patients who withdrew. Otherwise, everybody else is completing the study. So in summary, this was the first drug in its class orally developed for diabetic retinopathy. It targets REF1, which is plays a role both in VEGF signaling as well as inflammatory signaling. A fairly good safety profile with very few patients dropping out of the study or having complications. It is almost fully enrolled, and hopefully will be fully enrolled in next month. And I'm looking forward to seeing the results both for the diabetic retinopathy, and we're also looking at the kidney disease. So there may be a place that this may play a role in improving kidney function in these diabetic patients, as the mode of action is very similar to the retinopathy.
So the goal wasn't really to do diabetic macular edema, but really to look at reducing disease severity?
Correct. We'll get some hint about diabetic macular edema. Once Carmen, once you get into treating once the patients have diabetic macular edema, if they have any visual loss at all, you're obligated to treat them. And, then you're adding VEGF, and that would mean that you wouldn't be able to really know which was causing the improvement in diabetic retinopathy severity. So we will have some idea of whether this does work for diabetic macular edema, but the thought of this study was, if you can see these patients and treat them orally early, you may prevent vision-threatening complications, and you may be able to stop patients from going on to developing these changes. So that's really the goal, is to see how it affects the diabetic retinopathy severity.
How severe diabetic retinopathy was necessary to be enrolled in the study?
Well, they did 47, 53, and actually they did 61, which most people stay away from. But 61 is proliferative diabetic retinopathy without being clinically, meaningful. So in other words, if they had disc neovascularization greater than 200 microns, they would not be eligible because they would be high risk, or if they had hemorrhage and they had neovascularization elsewhere. But small tufts of neovascularization elsewhere were eligible, and we're going to see if this drug is able to reduce that. You will, get two-step improvements in your diabetic retinopathy. It may also give us an opportunity to see how these small tufts of neovascularization respond, and if they respond well, this may be an alternative to early treatment of some patients with early proliferative disease.
How did they document the findings in the study?
Fluorescein angiography documented, for diabetic retinopathy severity, it's 7 fields. It's the old 7 field, going way back to, 30, 40 years ago. For the neovascularization, they did do fluorescein angiography. So we will see some results and see if it changes the perfusion and changes whether the neovascularization or the ERMAs will go away.
And it's a 1-year study?
Yeah, it's a 1-year study.
Well, it's exciting.
Yeah, it takes us out of, making people pin cushions. It's nice to be able to, offer them something else beside an injection. Compliance may be better, and they may not have to return as often. There's a lot going on with patients being able to home monitor themselves for diabetic macular edema. So I think that in the future, I'm hoping that we don't have to see these patients and inject them as often.
Yeah. It's an exciting study. Look forward to the results. We'll hear about it next year at Angiogenesis, I guess.
It's always a pleasure to talk to you, Carmen. Stay well.
Thank you.